facet is that the area of the joint is comparatively more. They are forming the articular pillars, and sometimes this capsule is not very continuous. So these are the problems with the cervical epidural. And also, if you look at that C2, C3 becomes at the same plane, the first joint, because other two, C0, C1 and C1, C2 is slightly anteriorly placed. So facet can cause pain, and this type of pain is a paraspinal pain. It is paramedian pain. And sometimes you have to differentiate it from the myofascial pain because in a number of cases, sometimes they are becoming confused that whether it is myofascial or it is because of a cervical facet pain. Now, what is the definition of cervical facet pain? So, it is the pain that is originating from the cervical facet joint due to the degenerative or mechanical issues, and it can cause a neck pain which is commonly associated. Cervical facet joints are diarthrodial joints with having a synovial membrane. It's located between the C3 and C7 vertebrae, innervated by the medial branch of the segmental nerves. Remember, there is a difference between the lumbar and cervical, especially in the counting of the nerves. Why? Because at the cervical area, if you look at carefully, the nerves come above the level. For example, if it is a C4 cervical vertebra, the C4 nerve will come just in between the C3 and C4. Okay. Whereas in lumbar area, it is the opposite. It comes below the vertebra. So what happens in the lumbar area? If L3, L4 facet joint is affected, we are going to block at the level of the L2 and L3 nerve roots. But in the cervical area, it's not that. In the cervical area, if C3, C4 facet joint is affected, then we are going to block branches from the C3 and C4. This discrepancy occurs because of the counting error that originates from the presence of C8 as a nerve, but there is no C8 vertebra. And that's the reason why this discrepancy comes. Now, it happens commonly in middle-aged women and sometimes in male also. It is sometimes associated with the whiplash associated disorders, that is the acceleration deceleration type injury. Sometimes it could be associated with other traumas. Sometimes it could be associated with the inflammatory disorders, and definitely sometimes it could be associated with the degenerative disorders. Risk factors includes genetic predisposition, smoking, sedentary lifestyle, and nowadays computer-related works is also a very important factor that can cause cervical facet pain. Now coming to the symptoms and diagnosis. So what it causes? A cervical facet pain. It causes a unilateral neck pain. That means as the facet is situated not at the center, rather it's situated at the side. So it is usually affecting the side where it is affected. For example, if the left-sided facet joints are involved, pain will be towards the left side of the neck. If the right side is involved, pain will be towards the right side of the neck. Pain will be aggravated by the rotation and extension because facet joints are placed at the back of the spine. So whenever we are extending the head, there is more pressure of the facet joint and that will increase the pain originating from the facet. And also, while rotating, the pain increases. And there is also one thing which is said that if the upper facet joints are involved, then if you flex and rotate, the pain will be more. If lower facet joint are involved, then if you extend and rotate, the pain will be more. This is because the rotational force increases in the upper facetal areas whenever you are in a flexed position and rotating, and the rotational force increases in the lower facet when you are extending and rotating. So there are some difference by which you can make actually, which is the upper facet joint are involved or lower facet joints are involved. Now coming to the red flags. So what are the red flags we need to look for whenever we are suspecting a facet pain? First of all, neurological symptoms like weakness, numbness, tingling in the limbs, especially in the upper limb. And sometimes it could be associated with the loss of coordination, balance, bladder bowel control. So that means the patient is having more neurological symptoms. So these are constituents of the red flags. Next, coming to the recent significant trauma and minor trauma in the old patients as well. So these are also red flags. In those cases, you cannot wait. You have to go for the urgent management. Next comes to the constitutional and systemic symptoms. For example, unexpected weight loss, which could be a feature of an inflammatory disorder or it could be a feature of the malignancy. Fever, which could be again a feature of the inflammatory disorder or could be a feature of the again infection. The night sweats, other signs of infection. So if they are present, that is also becomes a red flag. Now coming to the cancer or inflammatory disc. So history of previous cancer and persistent night pain. So these are the red flags for the cervical facet pain. In physical examination, you have to go for the neurological test for the reflexes, sensation, and motor function. And we check for the pain upon pressure of the facet joints and in rotation and extension that at the position where facet is more stressed. Now, what we are going to do in the imaging? In the imaging, definitely we have the basic investigation like X-ray. Though the information we get on X-ray about the facet joint is very, very limited, except for the alignment changes, or in some cases it can show the disc height reduction. But usually the joint pathology, facet joint pathology is not clearly seen under the X-ray. So MRI and CT is used when the neurological symptoms are present. And also before doing any procedure, we usually check the MRI because there could be not only the facet, sometimes the other structures could be involved. So we have to rule out these conditions. And remember, there are situations when the facet can also cause the pain, which is a type of radicular pain. For example, if there is a facetal hypertrophy, which is compressing over the nerve, or there is a facetal cyst compressing over a nerve, or a osteophyte close to the facet joint that is compressing on the nerve. So they can also give rise to a radicular symptoms in such cases. Now, coming to the diagnostic intervention. There are two ways to diagnose this situation. One, just go inside the facet joint, inject small amount of local anesthetic, that is 0.5 cc of 1% lignocaine, most commonly used, and you check whether the pain relief is there or not. And the other way is just go to the nerve supply of the facet joint, that is the medial branch that supplies the nerve, and then you inject 0.5 ml local anesthetic in both the medial branches supplying a single facet joint and check whether the pain is relieved or not. But both the cases, which one is better? Remember, there are some advantage and disadvantages of both the procedures. But overall, it is said at the cervical region, it is the median branch block, which is comparatively safer and better compared with the intra-articular facet injection. So for the intra-articular facet injection, our purpose is mainly diagnostic and potentially therapeutic because we can include corticosteroid that can give rise to a comparatively longer term relief. Whereas in case of median branch block, it is purely diagnostic because it confirms the pain, but it cannot give any relief. Because if there is an inflammation in the facet, and if you are injecting small amount of the corticosteroid within the facet joint, there will be pain relief. But for the median branch block, we usually do not add any local anesthetic. Sorry, we do not add any steroid, so it's purely diagnostic procedure. Technique is local anesthetic plus corticosteroid injected directly into the joint. Here it is the local anesthetic injected on the nerve supply of the joint. Advantage of the intra-articular facet injection. First of all, it's the directly targeting the joint and immediate feedback from the patient about the pain force. Here, for the medial branch block, the advantage is it is comparatively easier to perform and covers multiple joints if overlap exists. And also, there are lower procedural risk in case of medial branch block. Now, disadvantage of the intra-articular injection includes technically more challenging. Basically, what is the advantage for the medial branch block? Because it is easier to perform, here it becomes the disadvantage because it is comparatively difficult to perform and there are risk of the joint trauma or infection as you are going inside the joint, and it is less effective if the pain is nerve mediated. Okay, and here it is the indirect method. Disadvantage of the medial branch block because it is not going directly in the joint and assessing the joint pain, rather any other structure. For example, if it is coming from the multifidus myofascial pain, that will also be blocked. Okay, so and the risk of false positive due to non-specific nerve hits. So they are the disadvantages for the medial branch block. But still, as far as the safety is concerned, it is usually considered safer in the cervical area, medial branch block. And also, one of the advantage of the medial branch block is that in future, what we are going to do? We are going to do a radiofrequency ablation. And the radiofrequency ablation can be done better because it has better prognostic value for the radiofrequency ablation. That is why medial branch block is preferred if you are going to do a subsequent radiofrequency ablation. Now coming to the indications. Indications are mostly the same. That is suspected intra-articular pathology, therapeutic steroid use is needed. And here medial branch block is usually first line diagnostic block if it is suspected in a facet pain. Therapeutic benefit, definitely, if you are giving steroid intraarticularly, you are getting a therapeutic benefit, but medial branch block, unless or until you are not performing a radiofrequency ablation, it is a purely diagnostic procedure. And intraarticular injection is less useful for the radiofrequency planning further, whereas the medial branch block is usually more useful if you are planning radiofrequency further. So I think you are able to understand this important part that whenever we are going for the intra-articular injection, now intra-articular injection we are giving within the area, that is within the joint. So it is a direct evidence of the joint pain. It is giving a therapeutic result, whereas the medial branch block, the nerves that is supplying the facet joint and blocking them, it is diagnostic and prognostically better. Now coming to the management options for a cervical facet pain. Remember, the initial phase management plan is usually conservative. That includes physiotherapy, manipulation, pharmacotherapy, and exercises with psychological support. If the patient is not responding, then go for the multidisciplinary approach. Even then, if the patient is not responding, then we should consider going for the interventional approach. Now, the question comes, where lies the medial branches? Remember, if I show you in a model, it will be much easier, I think. Let me take the model. Just look at it carefully. So here we are having the nerves. These are the nerves. Can you see this? This yellow portion are the nerves. So from these nerves, the branches are coming like this. Okay. So I am in the correct area. Branches are coming like this, then they are rotating. One going into the upper facet. I think I have to take it a little more closer. Okay. So from these nerves, branches are coming like this. From here, one going to the upper facet, one going to the lower facet. So at this area, especially if you look at from the anterior posterior view, you can see an undulation. And this lower portions, that means the depressions of these undulations, are usually location of the nerves, whereas the elevated portions are the portions which are the joints. So let's see how it looks. So if you look at this picture, okay, so Just check carefully. I am annotating. So at the sides of the vertebra, if you look at, see, there are elevations and depressions, elevations and depressions, elevations and depressions, again elevations and depressions. So these depressions are the location for the nerve. And if you look from the lateral view, hope you can remember the look of the lateral view of the spine. Let us see. I am drawing one structure. So what is this structure? Can anyone tell?
Body.
Vertebral body. Very good. What is this structure? Within the body, a small structure with the end on view. These are the transverse processes. We are seeing end on at this point. Then here we are seeing another structure. So what is this structure?
Articular pillar.
Articular pillar. Perfect. Next box is this one. What is this structure?
Lamina.
Lamina. Perfect. And the last one, but not the least, it is the spine. And this line, what I am drawing right now, it is red, so it is becoming red upon red. So this is known as the G line or spinolaminar line. Now, the rough locations of the median branch in this picture. So it is a rhomboid shaped structure. And if I draw two diagonals of the rhombus, then the center of those diagonals, this is the rough location of the median branch turning. Remember, in those days when there was no ultrasound, you used to do all the procedures with the fluoroscopy. Then this has a lot of value and we actually target at the center. But when the ultrasound came, as well as before ultrasound, when the cadaveric structure studies have been done, it has shown that there is a problem because at the level of the C5, it remains exactly at the center. But for the other levels, it moves slightly up from the center. But anyway, even those days when ultrasound was there, not there, we do not have any problem in diagnosing with the radiofrequency ablation. Can anyone tell why? Because we used to use the nerve stimulation. Even today, when we do radiofrequency ablation, after putting the needle properly, we do a nerve stimulation. And if the stimulation is coming more slightly above or slightly below, we usually adjust our needle accordingly. And then only after getting a successful sensory and motor stimulation, we go for the ablation. So that is why we actually able to target the nerve even without seeing it with the help of the fluoroscopy. So that was the part in the fluoroscopy. Now coming to the medial branch block. So what we are requiring, first of all, we'll require local anesthetic solution. In most cases, what we use is the 5.5% lignocaine, and it provides a short-term relief, not a long-term relief. And we have the intra-articular steroid injections, where we have the limited evidence of efficacy, use only within the clinical studies, but it has advantage of a little bit of therapeutic benefit. But thoracic intra-articular injection is comparatively difficult. Now, radiofrequency ablation is having advantages definitely. It can reduce the pain in long term and it can target the median branches. Now, there are in RFA procedure, there are two important parts. One, needle insertion under fluoroscopic guidance and electrical stimulation to confirm the correct placement. That is why even without seeing the median branches under the fluoroscopy, we are able to successfully give relief to number of patients. Nowadays, definitely with the ultrasound, it has become more easier, but with this it is possible. Now, if you look at the evidence summary, so what is there? Radiofrequency ablation, it is 2C plus because it is mostly supported by the observational studies. Median branch blocks having moderate support with 2B plus of evidence. Intra-articular injection is 0, that is no evidence. That is why Nowadays in the cervical area, it is used minimally. Now coming to the important considerations and complications. So what are the potential complications? So there could be intravascular injection, there could be nerve injury, there could be infection if not properly done. So we need to use the fluoroscopic guidance and maintain sterile aseptic precautions. So how we are going to approach the patient? First, exclude the red flags. If there is any neurological signs or any other disorders, we have to rule out. Go for the diagnostic blocks and go for the RFA if the patient is having a chronic pain. Now, there is a condition, sometimes it can be confused with the cervicogenic headache. That means cervicogenic headache because of the facetogenic origin, where the facet is involved and that is causing pain, and especially in the posterior part of the head and on the occipital neuralgia. Remember, cervicogenic headache because of the facetal origin or an occipital neuralgia, both can be present and both can come with a similar feature, that is pain coming from back of the head and going up to the head. But they differ in etiology and management. Whereas occipital neuralgia is mostly a neuropathic pain which is involving greater or lesser occipital nerve, which you all know, that is going through a muscular space, especially the greater occipital nerve, while rotating down the oblique scaputus inferior and going under the semispinal scaputus. It can be compressed there, or within the muscle of the trapezius, it can be trapped also. Whereas the lesser occipital nerve can be trapped in the fascial plane while it is coming from the arch point. Whereas cervicogenic headache is mainly the referred pain from the cervical spine structures C1 to C3, and accurate diagnosis is crucial, and that is done mostly through the diagnostic blocks. Now, occipital neuralgia, as it is a neuralgic pain, it will be a sharp shooting pain, electric shock like, and it will go to the occipital region, sometimes unilateral, and may radiate up to the vortex or behind the eye. Now, tenderness over the occipital nerve exit point, so it could be at the level of the nuchal ridge where the nerve is exiting, that could be painful, and it is caused by the nerve compression, sometimes trauma, arthritis, or idiopathic. Diagnosis is clinical or by the diagnostic or therapeutic occipital nerve block. Whereas the cervicogenic headache is because of the cervical structures, mainly from the facetogenic pain, and which is starting from the neck or the suboccipital region. It is often unilateral and aggravated by the neck movements or posture, and it involved restricted range of motion and sometimes muscle tightness. And usually the upper cervical joints, that is the C2, C3, is the most common, from where either from third occipital nerve, or it may, because third occipital nerve just goes above the C2, C3 joint, so it can take, or it could be a referred pain from those structures. And definitely it is confirmed by the diagnostic cervical median branch block or the facet joint blocks. Now, pain nature in occipital neuralgia will be sharp lancelating, whereas in cervicogenic headache, it will be dull pressure like. In occipital neuralgia, it will be sudden, and in cervicogenic headache, it should be comparatively gradual. Trigger point in occipital neuralgia is usually present within the muscle or just over the nerve, and here there is no specific nerve trigger for the cervicogenic headache. Neck movement impact, that means the pain, change of pain with the neck movement with the occipital neuralgia, is comparatively less, whereas in cervicogenic headache it is usually significant. And diagnostic block here for the occipital nerve block, in the cervicogenic headache it is the cervical median branch block. Now coming to the management. So in occipital neuralgia, initial part again conservative, then we can go for the diagnostic and therapeutic occipital nerve block. In previous days, when ultrasound was not there, we used to block occipital nerve as a much superficial pain just under the skin after it emerges from the trapezius. So it is in the skin and subcutaneous tissue. And here we used to do a pulse radio frequency ablation if it is not responding with the local anesthetic steroid injection. Remember, in those days we usually do not able to reach the deeper area. That means where the nerve is actually in between the semispinalis capitis and the obliquus capitis. But nowadays, definitely with the help of the ultrasound, we go there and inject. And in cervicogenic headache, initial part is the conservative management. If it is not responding, we have to go for the facet joint injections or the radiofrequency ablation. And in both the cases, multidisciplinary approach is beneficial. Now, I think it's the time you just see those procedures because I deliberately skipped the step-by-step procedure. The most important parts, including the complications I have told. So we'll be seeing the whole procedure now. Any questions?
Yes, about the
Yes.
previous lecture. The loss of resistant technique, there was no demonstration for this process. This is a question one.
A loss of resistance technique, it is not possible to demonstrate in a mannequin because mannequin don't have the epidural spaces. Okay. So loss
Okay,
of resistance technique is not new. So those who are in anesthesia, especially, they do not require this because they are doing it daily in everyday life. Loss of resistance technique is basically when we are putting the needle. So what happens? You are taking a syringe, and usually there is a specialized syringe which is known as the LVAR syringe. LVAR means loss of resistance. Now, this is a simple syringe where the resistance is low. That means when the piston is moving and moving in and out, the resistance is very low. And when it is put in a epidural needle, which is comparatively thicker compared to usually 16 or 18 gauge, and you are close to it. So whenever you are just putting in, so you will be getting, when we are pressing it, it will automatically, air will get compressed and the syringe will rebound automatically. Now, when we are just over the lamina and then we are going slightly above, puncturing the lamina. Okay, so what is happening when you are puncturing the not lamina but the this ligamentum flavum just above the lamina. So when we are puncturing it, so initially as long as you are above it, so you will be getting a continuous rebound of the syringe. As we just cross the ligamentum flavum, there will be certainly loss of this rebound. So what will happen? You put and the air will suddenly go in. Now there is also some question. Some say it is better with the saline. You should not be doing with the air. But as a general practice, usually it is done with the air only by most of the pain physicians or anesthesiologists. And when you will get the loss of resistance, that means initially the piston is rebounding, but once it is inside the epidural space, as the pressure is here negative or slightly positive or close to zero, so what will happen? The air will go inside and it will not bounce back. So that is known as the loss of resistance technique. But remember, it is not the only technique because there is another technique which is known as the water drop technique, where you can put a hanging water drop at the back of the syringe and you can check. There is also a balloon technique where it is known as the epicure, where one balloon was inflated with the help of a triway and you can look the balloon is getting deflated. But though there are a number of multiple procedures of this epidural detection exist, still one of the most common and most commonly performed area is the loss of resistance technique. So I think it is a very common technique, but still it is not possible to show in the mannequin. When we'll come for the workshop, definitely, if the cervical epidural case or is there or in any intralaminar epidural case, I will show that. But
okay.
there are some things that cannot be shown in the mannequin. Okay, this is one of the things.
When we do a pulse radio frequency for the dorsal root ganglion, uh, pulse radio frequency yeah, I saw the PDF. It is only one cycle, written about 42 degrees and 120 to
120 seconds, yes. That is the most common way of doing the pulse radio frequency. But remember, as the pulse radio frequency failure rate is very high, so a number of pain physician does 3 cycle at this point.
3 cycles. After this 3 cycles, do we inject any medication, steroid, or local anesthesia? I mean,
Usually at the root, steroid is contraindicated because the risk is more than the benefits. That is why in the root, it should be only the pulse radio frequency, not the steroid.
without using any medication.
Yes, no medication there.
After we do an epidural injection for the interlaminar technique, does the patient feel any weakness for how long? Because there's local
See, it all depends on how much concentration of local anesthetic you have given. Usually, the sensory block comes at 1%. Okay. The sympathetic block comes at 0.5%. And motor block comes at more than 1.5%. Though it is said that these are the usual concentrations for the local anesthetic for the specific blocks, those slight variation exist in patient to patient. And in most of the cases, the concentration we give is a very low concentration. That is, in most of the cases, we will be giving only 0.5%. That is why we usually do not get any weakness here. But definitely, you have to observe the patient. That is the most important thing.
Okay, thank you.
Sir,
Any other question? Yes.
sir, if blood comes in the epidural, what do we do? Do we remove it out, try again, or?
So first of all, try to deposition it. Okay. If the blood is coming, there is a possibility that is within the vessel. And when you are getting in an epidural needle, it is usually a comparatively larger vessel. It is not a small vessel because what happens? Capillaries are usually do not, these epidural needles do not usually go into the capillaries. So it is comparatively larger vessels. So first of all, the most important part is checking the coagulation profile. It should be normal. That is very important while thinking epidural, because if it is an epidural hematoma and it is compressing over the nerve, you are gone. That means ultimately you have to open. So in those cases, when you are getting blood, try to deposition once, try to giving aspirating again after depositioning, and also injecting the dye. So if you are getting vanishing sign, you are 100% sure within the vessel. After depositioning, if you get a very good epidural spread without vanishing sign, you can continue with the procedure. But otherwise, if you are feeling you are not safe, you can just postpone for that day and try from the other side in the next day. If you are thinking to go from going from the left side the previous day, now try from the right lamina.
Sir, also, why do we mix steroid and lignocaine? Like, we can use only steroid. We are dealing with inflammation.
Definitely you can use, but initial pain and spasm that comes after only steroid, it is not that some centers are using only steroid, okay? But usually it is seen if you give a very low concentration. Right now I use usually 0.5 or slightly less concentration of lignocaine. So in that case, the post-procedure pain is usually less compared with if you give only steroid. That is the only difficulty. But otherwise, if you give steroid only, that is also good. It is not bad.
Thank
Okay,
you.
and even there is a medical college that is in nearby in Kolkata, RG Medical College. There is a government pain clinic. So they always uses because they do not have the support system. If local anesthetic concentration is slightly more, they do not have every support system there. So they usually avoid in any epidural. They usually avoid the local anesthetic. They give only steroid.
Sir, what is the problem? Like, lignocaine, it can cause numbness.
Lignocaine.
It will cause numbness. That's why they are worried. Like, if it's a OPD procedure.
So what is the problem? That see, if you are experienced enough, there are no issues. But that's a training institute and a number of junior persons in the government training institute. So what happens is doing the procedure. So they made the protocol like this to avoid steroid because they don't want to get any complication because of the lignocaine. It is not a very long lasting complication because even if you give a very small amount of the very low concentration lignocaine, it is not going to harm. It might cause a little bit hypotension and not much thing. Okay, so ultimately patient will be recovered very soon. Okay, but still they avoid that.
Thank you, sir.
Sir, if we have to inject the drug at around C3 or C4, we have discussed that it is always safe to be at the level of C7T1 or C6
Say 6
T1.
or 7. Yes.
And can we use the catheter along the epidural needle to go to that
See, it
fluid?
is not required because whenever we give at the C78 level, usually when C71 level we inject 10 cc of fluid, it usually covers up to the C3, C4. So usually it is not required to give a catheter.
When we do lumbar, we usually say it is volume dependent. For if we have to go to C3 and C4, how much ml of drug we have to give, sir? As we discussed, it is like 0.5 to 1
In
ml.
most of the cases, see, in most of the cases we give 10 ml, and even the cervical space is much smaller. Okay, the width is very small. So what happens if you give a 2-3 cc of the this contrast agent, you will see it is covering 4-5 level, 2 level up, 2 level down. That is why if you are giving 10 cc, usually it covers the whole area.
Okay, sir. Okay.
You will
And
not require that.
okay.
Because here the space is very little, the width of the space is very little. So small volume covers a larger area at this point.
Okay, sir. And regarding the median branch block, we have discussed that it is only purely diagnostic. Can we use RF using an ultrasound, placing the nerve stimulator inside near the median branch and check for the sensory as a diagnostic approach instead of injecting a local anesthetic?
I could not get that. Though we are doing the radio frequency, na? So basically, radio frequency is the technique. See, when we are saying the diagnostic median branch block only with the local anesthetic, that is purely sensory procedure. But when we are doing the radio frequency, it's a therapeutic procedure. So the
So,
comparison is between the two diagnostic modes. That is
okay.
diagnostic, diagnostic intraarticular and the diagnostic medial branch block. Radio frequency ablation is always done for the after the diagnostic block, na?
Okay, sir. Okay. Thank you, sir.
Any other question? Otherwise, our Chinmada, please can you show the demonstration?
Yes, sir. About the reviewing of low back pain, I have some question about the lumbar area, but if there is another lecture, I will ask it later on.
Okay.
Okay,
But
lumbar one.
even today, if you after the class, if you have time, you can ask, no issues. Okay.
Okay, thank you.
Okay. So let us continue with the demonstration.
So we are going to show the cervical facet interventions. So what are the interventions? We can do actually 3 interventions. So our target is facet, that pain generator is cervical facet. But then either we can go inside the facet joint or we can target the nerve supply. In the nerve supply, we can go for either diagnostic or we can do radio frequency of medial branch block. Now, of course, radio frequency of medial branch block is always a therapeutic procedure. So before that, diagnostic intervention should be done. So diagnostic intervention should be the local anesthetic infiltration at the medial branch. Okay. Sometimes, of course, intra-articular local anesthetic infiltration also serves as a diagnostic evaluation that facet joint is causing the pain or not. Okay. So now this is the you can see the mannequin. Okay. So this side is right side, the patient is supine. So say patient is lying supine and this side right side, this side left side. Okay, cranial caudal, you can understand. So here first we will go for the facet joint, facet medial branch diagnostic block. Okay, which is the most important block. So here one thing you see that this is a lateral view. Okay, so here what we are seeing, so we are seeing the vertebral body, then we are seeing the transverse process. Okay, then these are the articular pillars, after that this part is the lamina. Okay, and then behind that this is the spinous process. Okay, so like that, this one is the spinous process, this part is spinous process. So always try to understand that the structure should be seen very carefully. Okay, here in cervical spine, though we are not seeing the vertebral artery, but it should be there in our mind always, that where can be the vertebral artery, because this is the most important and most dangerous structure in all cervical spine procedures. If we puncture that, then patient may die also. Okay, so where is the vertebral artery? Vertebral artery is going like this through the transverse foramen. Okay, transverse process in the intervertebral foramen. So this is the location. And so where is the intervertebral foramen location? So intervertebral foramen is here, in these areas, but we cannot see here. Okay, because this is a lateral view. If we see a foraminal view, then only we will be able to see the this one the foramen clearly. Okay, but when we are, so different different views are for different procedures. Last day I showed you a DRG radio frequency of the cervical area, DRG radio frequency. In that procedure we needed a foraminal view, but when we are targeting the medial branch for facet joint problem, like facet joint pain medial branch procedure, then we need only lateral view. So this is the lateral view. So here what we know, that these are the pillars. Okay, these are the pillars. So between these pillars, where is the location of the median branch? So median branch, say just in the middle part, here is our I mean, we target in this area, for we will make a tunnel view approach. Our needle will directly go here and touch in the middle part. This tunnel view approach in the middle part of the pillar to do a diagnostic medial branch block here. Okay, so one more important thing is, in a normal patient, like you see this head, so this head is straight here and we are seeing a lateral view. But it is possible that head is not quite straight. It is a bit right side deviated or left side deviated, or even from outside it looks like that patient is lying straight, but his spine may be right side deviated, left side deviated. So how we will know that if there is some deviation or not? So here you see these lines. Okay, this is one line, this is one line, and you can see the in between facet joint space we are seeing very nicely. But it could have happened that here also two lines and here also two lines. It could have been a 4-line thing. Then you understand that head is actually not straight, it is deviated somewhere. Even this line is overlapped. This is posterior side, and this is cranial side. This one is cranial side. So either this cranial caudal, these two lines can become, I mean, not overlapped. These lines may not become clear one line and may become two lines. Okay, this is also possible. Or these lines also may become not one line, it may become two lines. Okay, so in what condition? So in this red lines will become two if the head is not straight and like this, either tilted towards left or tilted towards right. Whereas yellow line will become two if the head is not tilted but deviated towards right or deviated towards left. So these are two conditions. So I show you that how it is, it shows if it is deviated. So here I am deviating it. Okay, so I am just making it like this. So you see, so you can see earlier these areas were very nicely seen, very nicely joints were seen. Now you cannot make out anything. That these lines has become two lines. So these are not the correct one. Now I am bringing it in the earlier position. Okay, gradually bringing it. Okay, shoots. So it is again coming in position. Okay, so you can see these two lines have become clear now, overlapped. These are also overlapped, these are also overlapped. Okay, So every place is not as clear as this one because it is a mannequin and we have put different articles inside, but then this is completely overlapped. So you can see that how it looks if it is deviated. So while seeing a lateral view, our intention is to see a true lateral view. So this is a true lateral view. Now, as I was deviating this side, that side, now I am making it tilted. Now let's see. So you see what has happened. Now posterior side, here two lines have come, here two lines have come, here two lines have come. So this is called tilting. So now I have made it again in the earlier position. Now this has become normal. So here I have moved the head, but sometimes in patients, when you see that from outside everything is normal, but the two lines are coming, then you will move the C-arm and not the patient's head. Then either if you feel that it is tilted like this, then C-arm will go up or down like this. And if it is, you feel that deviated this side, that side, then your C-arm will come like this or like this. Okay, so these things you have to change. Of course, we just adjust sometimes patient's head also a bit to make it all right, because that is much easier. Adjusting the patient's head position is much easier. So, but our aim is to make the pillars overlap from both the sides, from right side and left side. Now question is to see the level. So we can understand this is two biggest transverse process, spinous process, biggest spinous process. So this is 2, 3, 4, 5, 6. Here 7 is not there. This is 6, 5, 4, 3, 2. So C7 is not there in this mannequin. Anyway, so here if we target say C5, 6, usually C5, 6, C7, these are mostly affected joints. Okay, these are mostly commonly affected facet joints, not the above ones. So this is C4, 5 and this is C5, 6. So let us say I target C5 and C4, 5, C4 and C5. These two medial branches supply this one. Okay, and how will you choose right side or left side? So your point of entry, if it is from right side of the neck, it is going to hit the right side of the facet. And if it is right medial branches, right facet, and if it is going from the left side, then you are going to hit the left median branches. Okay, so here let me target the C5. Okay, so I am on so here I am going a bit posterior. I am going here. Okay, sure. Hmm. Hmm. Ta-da. Hmm. Okay. Okay. So this is the area where I should go for C4. C4 medial branches. And here, as I told you, these are all tunnel view approaches. These are tunnel view approaches. Okay.
Sorry, sir, for the lumbar region, we used to do not a tunnel view in the lumbar region. We used to do it from below or caudally and goes upward, right?
No,
For comparison.
lumbar area also it is tunnel view only. Medial branch is always tunnel view. Eye of the scotidor.
Sorry, I mean in RF. In RF.
RF. In RF, not tunnel view. Here also in RF, we are not going for tunnel view. That is a different procedure. At present, I am targeting the median branch for diagnostic procedure. Okay. Should this is not RF. This is diagnostic procedure. So we can see that the tip. So here the plastic round area we can see here. So we can understand that this is the hub. This is the hub. But I am going a bit more posteriorly, so I will make it a bit more anterior. Should. But I am going a bit now more anterior, more cranial. So I'll go a bit caudal and So though the needle is not in a tunnel view, but the main shoot. Okay. So needle is not in a tunnel view, but the tip has reached the right part. Okay, this is over the pillar and more or less on the middle part only. So I mean, this is a acceptable needle position. Here you can give small amount of local anesthetic to block the C4 medial branch. Okay. Now another needle we can put at the C5. So here should just remember, I should not go anteriorly so much that I should not hit the vertebral artery. This area is vertebral artery. My needle must not go anteriorly to hit the vertebral artery. Other all positions are all right. If I go a bit cranial, caudal, that doesn't matter. So upper one is okay, lower one is a bit caudal. I have to put it a bit caudal. So more or less tip is all right. Okay. So here also the tip is here. So this is also over the pillar. Both the needles are not in a tunnel view thing, but the tip is touching the correct position. Okay. So this is okay. So tip is all right. Okay. So here this one was C4, this one was C5. So if this patient has right-sided C4-5 facet joint, okay, then over these two areas, I will give local anesthetic 0.5 ml, 0.5 ml to block the in-between facet joint here. Okay, that will serve as a diagnostic medial branch block. Okay, any question here? Okay, so this is the diagnostic medial branch block. Now I show you the medial branch only, but it is the radio frequency of medial branch.
Sir, if it involves C5 joint, we have to block C4 and C5. If it involves both C4 and C5, we have to go one level above C3, C4 and C5, sir.
I could not get your question. Actually, the facets, the articular processes, which are both are making one facet joint. So
Yes,
you have
sir.
to go, always you have to go one level above, one level below. Okay, theoretically, nerve root changes, like say in cervical area, C4-5 is made by C4 and C5 medial branches. But
Okay.
in the lumbar area, L4-5 is made, this nerve supplied by not L4 or L5. Then it is L3 and L4. But this is theoretical concern. In practical, wherever is the facet joint, you will go above that and below that, targeting both the medial branches. That's it.
Okay, sir. Okay. Thank you, sir.
Shoot. So now we are going for cervical medial branches radio frequency. Now remember, earlier I was doing the medial branches diagnostic. So in diagnostic, patient was lying supine. But when I am doing a this one, your radio frequency of cervical medial branch, then patient's position is prone. So you know, this is cranial, this is caudal, this side right side, this side left side. And so every time before starting, I will always see that what is the level, which side is right side and which side is left side. So just let me check that right is right. So right side is right side. It's okay. So now, okay, bring it medial. Cannot turn it. Just okay. Now this is the AP view. We can see, so this trough and heel like this. Here also. So I mean, as such, the trough area, these are for medial branches. Medial branches, medial branches, medial branches, medial branches. And the heel areas are for facet joint, facet joint, facet joint. Okay. So these are facet joints, these are facet joints. But we do not need to know that much, need to think about that much. Say this patient has left C5, C6 facet joint. Okay. So we know that this side is left, and which is C5, C6. So we know that this one is T1, this one is C7, and this one is 6, this one is 5. So at the level of C6, I can enter from here, or I will enter a bit below. I will just enter from here. What I will do, I will just touch the lamina here. Okay, I will touch the lamina, and then I will count the level from the lateral side. So here just you can see, I think. Oh. So just see one thing, that this one is the cervical spine. So from posterior side, so these are the pillars, these are the pillars, and we want to reach here. So from posterior side, see, there is not much structure. These are the spinous processes, and this is the lamina, and lamina is continuous with the pillar. Okay, lamina is just continuous with the pillar. So you don't have to worry about that what I am going to hit. If you hit, you have to hit a bone only. That's it. You will hit a bone and just you miss the bone. You will hit a bone and you just miss the bone. When you miss the bone, you are on the pillar. You are on the pillar. Okay. These are the pillars. You just miss the bone, you are on the pillar. Here also, you have missed the bone, you are on the pillar. So that is what. And then we will count that we want to go to the left C5, C6. That's it. So here I am just going to first hit the lamina. Shoot. Okay. So okay. So here I am just I have just put the forceps on the C6-7 area nearly. Shoot. So here I will put the needle straight, and I will keep my needle tip towards medial side. Should. So I just want not that medial, I just want to hit the lamina. I just want to hit the lamina. Just shoot. Not lamina. I just want to hit the articular pillar. Okay. Okay. So now here we know that I am going to. I'm just on a bone. I'm just on a bone. So I'm just walking on the lateral side. Shoot. I have just walked on a lateral side and I can feel that I'm just missing the bone. That's it. Okay. Now I'm putting another needle. Just below that, I'm putting another needle in the same way, and should I will hit the bone. So here also I will just hit the bone in the medial side. So I'm hitting the bone. Should I'm going too medial, so that is not acceptable. Okay, should. So I'm again hitting the bone, and now I'm going a bit laterally to see that if I can just miss the bone. Okay, should. Should. Okay, should. So both the needles are in the same line. I am just missing the bone. Now what I will do, I will see laterally that where I have come. I want to go C5, 6, right side facet joint. Now I will count. Okay. So here, we are seeing the anterior side too much. So I want to go above a bit more. Okay. So here I can count. So I can count. I can count from above also, from the above also. Okay. So you can see this one is 2. We can see the big spinous process 3, 4, 5, 6. So this is around at the C5, 6. But of course, if it comes like this, then it will not come in the middle part of the facet. So I have to change the direction like this, and it has to reach here like this. So I will change the direction here, and here also I will adjust the direction a bit to reach in this place. Okay. So that is not very tough here. Sometimes things become a bit tough on the mannequin, but not on the normal patients. So it has nearly reached. So this is the correct area. This is the correct area, upper one. Now lower one. I will go a bit up. So direction is okay now. Now also I have to just work on the bone to go on the lateral side. Okay. So this is also going in the right part. Okay. So both the needle has reached in the right area. Okay. Okay. So both the needle has reached in the right area. So another, I mean, for one medial branch, in conventional RF, you have to do three lesions. So after making one lesion at this area, you can put the needle a bit down like this, and then a bit down like this. Okay, then three lesions can be done. Here also, after doing this lesion, you put like this, and then again one needle you put like this. So another two lesions, total three lesions. So here is one median branch and here is one median branch. Okay, so these are the procedures, and so this is the median branch procedure. Okay, understood? Any question? Oh, AP view just show. So AP view also you see that whether really you are touching the bony margin or not. This is the lateral view we can see, though of course we work on the bone only, but in AP view you can see you are just touching the bony margin. So this is the final view in the needle position. Okay. So any question here?
For the lesioning, do we use any medication like local anesthesia or steroid?
Just a minute. No, here you are saying that any medication or not. No, after radiofrequency, you can put this one dexamethasone, small amount of 1 mg dexamethasone, just for avoid the neuritis. If you are doing a conventional RF, you can give some dexamethasone here, 1 mg, like that. So this was your question, no?
Yes, and we do not need local anesthesia if it is.
Local anesthesia we have to give before every radio frequency. I mean, before the listening starts. Okay. So after you have put the needle in the right place, then you go for sensory stimulation, then you go for motor stimulation, then you go for local anesthetic, 0.5 ml local anesthetic. Then you do the listening. Otherwise, patient with 80 degrees temperature or 75-degree temperature, patient will get pain. So that time you have to give a small amount of local anesthetic. That's it. And sensory stimulation will tell you that whether you are close to the nerve or not. And motor stimulation will tell you are not close to the radical main somatic roots. You are not close to the somatic roots. That's it. Otherwise, it will not tell any other thing. Okay.
And now we RF for the C7, C5, C6. So we do two medial branches, the C6
Yes,
and
yes.
because the C7 supply the above vertebra.
No, at the cervical level, it is the same levels. Okay.
Yes,
So
it will be C6. For the facet joint of C5, 6. The C6 supply the same level, but
yes,
the
yes.
the C6 C5 C6 facet joint will take a branch from above from sorry يعني C7 will supply the same. Each median branch block supply the same level and one level above.
Yes, yes, yes. That is okay. Yeah.
This
So
is
yeah, that is okay. You just remember in this way practically when the facet joint is made by two articular pillars. So just above that facet joint, your target will be there on that articular pillar, and below that facet joint, there will be another articular pillar. I mean, there will be another median branch. That's it. Okay.
Sir,
Okay.
so if two joints are involved, 3 levels I have to give.
Yes, 3 levels, of course. If consequent 2 joints are involved, one after another, then three levels. Yes, true. So this is the way how you put it. And another another procedure, which is intra-articular facet joint injection. Usually we do not do. That is very risky procedure. You can say a bit risky procedure. But if someone wants to know, then we can of course show you. But so here just you need to do a bit caudal approach. So in different, just make it caudal a bit. This is a bit risky because local anesthetic or needle can go here and there. So when we do a bit caudal, then we see these facet joints open. Facet joints open. I have to caudal go. Yeah. So at different level, these facet joints open. So this is one facet joint. So either we can go from the posterior side, in a tunnel view approach, that is also possible, or you can go from the lateral side. When patient is lying laterally, then also you can go. In the supine also, we can go inside the joint, like we are going in a tunnel view approach on the pillar, we can go inside a joint, okay? But then here it is a bit risky, so I don't want to show you much here. Intra-articular cervical facet joint. Sure. Okay, sure. So this is one facet joint. So we have to go like this straight, and we have to remain lateral. We have to remain lateral. Our needle must not go medial. And then we will, I mean, I am just hitting the articular pillar here. Now I will walk over the articular pillar, and then I will enter inside the facet joint. Okay. So here I can actually understand that I am inside a facet joint, but so here I can, so this is the lateral view. I mean, this is the AP view. In lateral view also, you can see that whether you have reached in the facet joint area or not. But then this is here also you should not go medially or laterally. There is no important thing, but you should not go medially. So.
Sir, medially vertebral artery to avoid, we should not go.
Medially, no, there is not vertebral artery. You can enter between two laminas. It can be a epidural. I mean, you can inadvertently go in between two laminas. That is it. So it has not reached. So now, so it is actually here. So here we cannot go much in, but yeah, sure. So here, yeah, Our from lateral view, it will we will see like this only, and from in epi view, we have to see that we are just between the pillars. We have not gone medially, and you will of course get a loss of resistance. Yeah, so we are between the pillars only, and we have not gone medially. So this is the intra-articular joint injection. But this intra-articular joint injection is a bit not that much practiced nowadays in cervical area mostly. Okay, so always go for median branch block. Okay.
Sir, can it happen that my needle moved? Like initially, I got to view everything while giving the drug. If needle moves, like, or I have to be careful.
Now, while giving the drug, needle should not move. You now, what can be done? I mean, if you think that it has moved, then you have to reposition it again, recheck. It should not move. There
But
is
these spinal needles, they easily move in. Like, if I'm on the bone, I will stay on the bone. But
easily moves, but no, but I mean, these are quite deep, so it should not move. I mean, this you have to take care. I mean, there is no other way.
yes,
It's a practice. So keep one hand fixed with the needle, inject with the other drug, or other hand. And another way that could be sometimes done by new physicians is putting a trivay before head and injecting through that trivay.
Yeah, like say celiac plexus block. In some cases, I always use a connecting line. I do not touch there. If there is a matter of 1 millimeter going deep or come superficial is a big thing, then I do not touch. I will make a connecting line and I do not touch at that area.
yes. Sir, also epidural, can't we use spinal needle because we're not putting the catheter. So,
No. Spinal needle in epidural area. But you want some loss of resistance after this one, no? Puncturing the ligamentum phlebum. You will not get with spinal needle. So it should not be done. Everyone knows, I mean, anesthesia people always knows that what is the loss of resistance feeling? It is like puncturing a water-filled balloon. As soon as it punctures, that give away that feeling is the loss of resistance feeling.
but sir, like I asked because it feels very invasive, a bigger bore, like that way I asked. Spinal is smaller, yeah, but loss of
No.
resistance we need,
Loss
yes.
of resistance is must. You will not feel any
Yes.
loss of resistance with spinal. So that is risky. Okay.
So while using nerve stimulator in case of medial branch block, how much milliampere hertz should we set?
And not only here, in every case, everywhere, sensory stimulation parameter is same, motor parameter stimulation parameter is same. In terms of frequency, 50 hertz is for sensory stimulation, 2 hertz for motor stimulation. Of course, in 1 hertz also motor stimulation occurs, but mainly 2 hertz for motor, 50 hertz for sensory. That's it. Volt you have to go on increasing like that.
So in the lumbar region was the multifidus in the motor stimulation.
Yeah, theoretically here also it should come,
Also
but our main intention is to exclude the
radical.
radical, exclude the main serious thing. If the this multifidus doesn't show you twitching, then also you can say that it is in the right place. It is every time it is not seen clearly in cervical area.
Sir, in lumbar also, can we do transforaminal or do we prefer interlaminar only? Epidural steroid.
No, lumbar transforaminal is done, not interlaminar. Interlaminar is not done at present in chronic pain in lumbar area. Lumbar area only transforaminal, mainly. Interlaminar hardly anyone does, but in cervical, interlaminar and not transforaminal.
Why, sir? Is there benefit?
Vessel, vascular. You do not want to, I mean, you want to do good of the patient, but not at your own risk, no? So, I mean, in cervical area, so many vessels, there is a chance of complication. So, I mean, there is a more chance of complication. That's why, nothing else.
No, sir.
and
In lumbar is the benefit more with transforaminal than interlaminar?
I think transforaminal is a bit better, but as I am saying that if the world is saying that don't do it for complication purpose to
Yes.
avoid the complication, then we should not do it. Otherwise, we did transforaminal earlier 10 years back. But now, I mean, everyone is saying that you should not do, then you should not go against the global verdict.
Yes.
Sir, for the transforaminal epidural injection in the lumbar region, if we do radiofrequency ablation, is the needle also not in the tunnel view?
Um,
I mean, in the medial branch radiofrequency, the needle was in not a tunnel view. In the trans
yeah,
also we
I
do a
mean,
tunnel.
no, it is not hard and fast that it can be in tunnel view. It can be in tunnel view, but of course, we will adjust it by seeing the lateral view. We will adjust it by seeing the lateral view, so it may not be in a tunnel view. While entering, it is in a tunnel view, of course, because we are entering in AP view. AP view, we will enter, but fine adjustment we will do while seeing the lateral view, and then we may see that it is not in a tunnel view anymore.
Okay, thank you.
Okay, Devjyoti.
Starting.
So small topic, trigeminal, occipital neuralgia is remaining. Yeah. Oh.
Okay, please join. Hello, am I audible? It's not showing.
Yes, you are audible.
Okay. Please join. I've already shared.
Haunted IQ. Haunted IQ. Nanometer. Dr. Thanagai. Anne. Dr. Inni. Mama
House
Woman.
Nut.
Doctor. S. Bisak. Freak King. Bouncy
Party.
Woman. Dr.
Clever Doc.
Indu. Freak Rabbit. Hi.
Okay, let's start.
Quiz.com. Play and create.
Which symptom is most characteristic of cervical facet joint pain?
Housewoman joined.
Axial neck pain without neurological deficits. Pain from cervical facet joints typically
Cool
worsens with
police
which
joined.
movement?
DRNOPAIN joined.
Neck extension and rotation. Which feature helps differentiate cervical facet joint pain from radiculopathy? Absence of arm pain and neurological deficits. What is the primary purpose of medial branch blocks in cervical facet joint pain? Diagnostic confirmation of facet joint involvement. Which imaging modality best shows bony anatomy of cervical facet joints?
JJ joined.
CT scan. Which of the following is not typically involved in cervical facet joint pain?
Cool police joined.
Muscle weakness. What is the main goal of radiofrequency ablation in facet joint pain? To destroy medial branch nerves and interrupt pain. What is a limitation of using imaging alone in diagnosing cervical facet pain? Poor correlation between degenerative changes and symptoms. Which of the following is least supported by evidence as a treatment for cervical facet joint pain? Intra-articular steroid injections.
Final question. Double points.
Which structure is targeted during a medial branch block? Medial branch of the dorsal ramus.
Third place. Dr. Thanagai. Second place. House Nut. And the winner is Freak King.
So who is the winner today? No one is responding.
Dr. Bharat. Okay.
Freak King.
Thank you.
Okay, let's conclude the class today. And say bye-bye to all of you.
Okay. Bye-bye. Good night.
Thank you, sir.
Thank you.